There's a lot of research going on in the first trimester. We know about the NIP story. We know about the first trimester screening for trisomy. It was the main screening approach within the last 10 years. We know there are plenty of other screening algorithms for preeclampsia, gestational diabetes, and growth restriction. So there's a lot of research going on in the first trimester, and that has even evolved to a system where we now discuss whether it may be worth changing the management of all pregnancies, but that's just still future, and that's just research. So there's still the need of concentrating to what is really necessary in the first trimester to really give some guidelines of what should be seen in the first trimester and what is just research and shouldn't be applied yet in a clinical setup. And there's a nice guideline that's been published by the ISUOG, and that's freely available on the homepage and on the web, and I will refer to that one within my presentation. And I think one of the main issues that we always should keep in mind is that what we do is to provide accurate information which will facilitate the delivery of an optimized antenatal care with the best possible outcome for the mother and the fetus. So that's the basis of everything, and it's not just that we can pick up something strange that we're very much upset about, but it's really to deliver optimized care. And now I won't go into all details that what can be seen in the first trimester. The topics for today's talks are: how does normal anatomy look like? What should we look for? How does the normal nuclear translucency measurement work? How should it look for? We'll talk about trisomy 21 shortly, but that should be a different discussion, different presentation. We discuss all chromosomal abnormalities and typical anatomical defects. So we'll talk about anencephaly, holoprosencephaly, abdominal wall defects, and megacystis. There are plenty of other things, and you can detect about half of all major anomalies, even in the first trimester, but I think that would be too intense for now. We'll keep it shortly, and we'll concentrate on these anomalies. Now, the ISUOG has published a long list of things that could be seen, and if you look to these bits, then you can see that these are well known from the second trimester as well. So you should have a look to the head, and you should see the cranial bones, the midline falx, you should see the plexus, you should see the neck, and after counseling you should measure the nuclear translucency measurement, see the face, and the eyes, and the nose bone. You can even see the lips. It doesn't work all the time, but if you use a transvaginal approach, you can see the lips quite clearly. Have a look into the spine, to the chest, heart, the abdomen, abdominal wall, especially extremities. And don't forget the placenta, because placenta previa totalis at this early gestation, if the cervix is right in the middle of this, the placenta, it's questionable whether this one will go away. Let me go through those topics, and I'd like to demonstrate how these things should look like. So the first thing you should see is the brain. You can see the brain quite clearly here. Actually, you can see the two plexus here. You can see the cranial bones. You see the falx here. And you've excluded, with that so-called butterfly sign, you've excluded anencephaly and holoprosencephaly. Carry on, as already mentioned, to the neck. You can see the profile at one glance, and you see the normal nuclear translucency. And actually, nowadays, you also look to that area, which is called the intracranial lucency, which may be a hint for spina bifida, which is extremely difficult to detect. And previous studies have indicated that you may pick up about 10% of spina bifida just by looking to the spine the first trimester, but not more than that. And by looking to that intracranial part here, may increase the detection rate. Well, prospective studies have not been made yet, but may increase the detection rate to 60–70%, perhaps. Go a bit further down, you can see both eyes, and you can actually see the lenses here quite clearly. You do have a look to the retronasal triangle, and you can see that bone here, which actually reflects the maxilla. And, well, excluding cleft lip may be very difficult, but excluding cleft palate may be easier by looking to that triangle. If you see a straight line here, then it's not so likely to have a cleft lip, a cleft palate. As I mentioned, you can see the lips quite clearly if you do transvaginal ultrasound here. Transabdominally, it's really difficult. And I would be really careful excluding or actually diagnosing cleft lips at this early gestation. But in these cases, as you see it here, it's very obvious that the lips look okay. Once more, you go to the profile. You can see whether there's a micrognathia or retrognathia. That can be seen quite clearly. And actually, in these cases where you suspect micrognathia, the condition is worse or looks worse in the first trimester than it does in the second trimester. So even if there's a big stab, in these cases, it doesn't look as bad as in the second trimester again. Already mentioned, you look to the spine, you can quite clearly see the spine, but again, transvaginally, and not always you'll get so good images as in this situation. And therefore, you'll focus on the intracranial lucency here, and it's recommended to measure it, but only by spotting it, you can see 3 black lines here, and that black spaces here, and that's a good sign that there is no spina bifida. You'll carry on with the heart, and it does take a bit of time until you get to a situation where you can do a first trimester cardiac scan. But by just looking to the 4 chambers, you do get an impression, and you may be able to exclude at least some cases of hypoplastic left heart and an AVSD. So no one would actually ask you to exclude a transposition of the great arteries, for example, but at least some of the major heart defects may be spotted at this early gestation. Use color flow. It helps to look to the inflow of the chambers and, of course, to the outflow. And it's much easier if you can demonstrate here an antegrade flow in the great arteries. At least you've excluded most of the cases of left and right outflow obstruction. Of course, you could have a look to the tricuspid blood flow, but already that is a bit more sophisticated. And the same is true for the ductus venosus. It needs a bit more training. We've done with the time when I worked with Professor Nicolaitis, then we've done studies to see how many examinations you need until you get experience with that kind of examinations, and a good 100 to 120 examinations are necessary to produce reproducible results with these with the tricuspid and the ductus venosus blood flow. Carry on. Have a look to the diaphragm on both sides, and sometimes you may spot diaphragmatic hernia, but not in all cases. So again, don't worry if you missed diaphragmatic hernia in the first trimester. That is better to be diagnosed in the second trimester. But if you see diaphragmatic hernia in the first trimester, they do have a bad prognosis because the hole in the diaphragm is much bigger, and the organs are already pushed upwards, and the lungs are much smaller in these situations. There's the other diaphragm. You go a bit further down, you see the abdomen, you can see the stomach here, below the heart. And have a look to the bladder, and you see 2 umbilical arteries here. You can see 2 kidneys, and obviously the insertion of the umbilical cord. And the legs, you may spot the toes, and the fingers and the arms. So it looks very difficult, and you obviously look to the whole baby. You measure the CRL in a neutral position, not too much flexed, not too much extended, otherwise you will overestimate the CRL. As I mentioned, don't forget the placenta, maybe in a difficult position, so check in the first trimester. That is a good opportunity. Although these images look nice, you can really demonstrate this in this small clip, and I hope it works. That is a pity. If this one doesn't work, it means that the other ones are not working as well. So we double-checked it in the office before. Oh, all right. Shame. Now, what I wanted to demonstrate is that these images that I've selected for you, these were selected cases where you can visualize these things extremely well. But you can do it transvaginally, for example, in a 2-3 minute scan quite easily. And the more you try, and the better you get with it. And don't lose the opportunity to do a transvaginal ultrasound, because all these conditions that I've shown you are mainly seen transvaginally, and obviously you can do it transabdominally as well, but it's much easier transvaginally. And imagine in obese women, for example, where you do have problems to get these images transabdominally, you can quite easily select them transvaginally. So, for example, imagine the hand. If you see a nice hand with 5 fingers in the first trimester that you've seen transvaginally, then you're safe. And imagine how difficult it is at 20 weeks. The baby's laying in a difficult position with the hands just been in little fists. So, but if you've demonstrated in this condition a nice hand in the first trimester, then you're on the safe side. So I hope the other videos are working. But what can we do now to help ourselves in this situation? Well, we can at least look for the right gestational age. And if we try to examine all these anatomical structures at 11 weeks, the success rate is much lower than it is at 12 and 13 weeks. With nuclear translucency scanning, we recommended to do the scan at about 12 weeks, because that is a good time where we can actually see the nucleus clearly enough, we can see the anatomical structures good enough, and the screening performance is acceptably good. It would be better at 11 weeks than at 13 weeks, but nowadays as nuclear and first trimester screening doesn't play that major role anymore in view of NIP diagnosis, I would actually recommend doing the anatomical scans at 13 or even at 14 weeks to visualize all these issues. And you can see here how much higher detection rates between 11 and 14 weeks are. We all know how much more difficult it is, even with measuring the nuchal at 11 weeks, than it is at 13 weeks. Now, right, yes, these ones at least are working. Imagine such a woman for the first trimester scan. It's a real challenge, and this is a situation where I've done a first trimester anomaly scan and where you can't really see too much when you do it transabdominally. If you go for a transvaginal scan, you can immediately see the structures in a much better way, so don't lose that opportunity to get a good approach or get a good overview of the anatomy. And as I mentioned, it takes you 2-3 minutes and you've done the whole anatomical scan, and it takes you 20-25 minutes in the second trimester. Let's spend some more words in how to measure the nuclear translucency. And there are basic rules that's been made by the Fetal Medicine Foundation, and they're well known. And I think what we should actually add, and that was never added before, we should only measure it after profound counseling. If you just see a patient, you measure the nuclear translucency and it's 3.5, and she will tell you, I don't want any screening, you're in a big mess. So before you really start measuring the nuchal, start counseling her first about the implications of nuclear translucency measurements. And then you look for the right timing. It's between 11 and 13 weeks, but it actually corresponds to 45 to 84 millimeters. The fetus should be in a mid-sagittal position, in a neutral position. If it's overextended or flexed, the nuchal will be over or underestimated. The baby, you shouldn't get confused with the amnion. You should measure the nuclear translucency, not the distance between the skin and the amnion. Should have a maximum magnification, so it should be a large picture where you only see the chest and the head of the baby. You should have a good machine, which is actually, which was a problem perhaps in the 1990s, but which is not the case today anymore. Should measure it caliper on-to-on, so you should only measure that plex space, and you should take the largest measurement, even though it may be in the occiput area and not just in the nuclear area. It's called nuclear translucency, but it could also be occipital translucency. The largest measurement should be taken for this. And I hope the next video works. We'll see in a sec. Now that's a video of how, another one that's not working, unfortunately. Let me just see. Yes, it does. Look, it's obviously the baby's in a good position. I'll do the first magnification and concentrate on the head and on the chest. And then you magnify it, and it will be brighter, so you turn down the gain again. And here you can clearly see the nuclear translucency, and try to keep those lines horizontally, because then they're brighter and you can clearly see them. If they're more or less vertically, you won't get such a good discrimination, and then you measure it on-to-on. That's a bit too dark here, but there you can see it, and then you get to the to the nuclear translucency measurement. Repeat those measurements for 2-3 times and take the largest one that you've taken. If the baby's facing downwards, that's not a big problem. Just measure it and switch the image, and all the ultrasound machines do have the chance to switch the image. And if the picture looks good after having switched it, then it's absolutely fine. If you've got a cord, that makes life a bit more difficult because the baby may be fixed in a certain position. Measure it. If you do get a good position, then measure it before and after, or above the umbilical, the nuchal cord, and take the average of both measurements. Now that's the distribution of nuclear translucency thicknesses, and you see that it depends on the size of the fetus. And just as a hint, if you do see measurements of below 1 millimeters, forget them. They're just not true. Okay. So the first centile throughout the whole timing when we can do first trimester screening, the first centile is at about 1.0 millimeters. So if I find in a German Mutterpass a measurement of 0.6 millimeters, forget it. It's just not true. Okay? So you can't rely on measurements that are below 1 millimeter. Repeat your measurements. I'm sure it's bigger, and it should be, let's say the median is about 1.5 to 2 millimeters. So that would be an absolutely normal measurement. We slightly increased if you look to the median curve here, but absolutely clinically absolutely right, even with fetuses of 45 millimeters, and the same is true at 84 millimeters. So if you do see measurements of 2.6 millimeters, for example, don't get worried. And if the baby is large enough, you're still within the normal range. Okay. If you do the scan at about 45 millimeters CL, well, then you're above the 95th centile. But most of them you'll see at about 75 to 80 millimeters or 65 to 80 millimeters, and you're still within the normal range. Okay, so there are previous recommendations that if the nucleus is above 2.5 millimeters, you should get worried. Don't worry too much. It really depends on the size of the baby, and if the baby is a bit bigger, that's within the normal range. Try to be exact with the mid-sagittal section, okay? Because as soon as you deviate to the one or to the other side, you will underestimate the nuclear translucency measurement. We've done a 3D study some years ago where we really looked to what happens to the nuclear translucency measurements in a 3D block where we deviate from 15 to 25 degrees. And why did we decide for these deviations? Well, with 15 degrees, you don't see the tip of the nose anymore. Okay? And with 25 degrees, you don't see the maxilla anymore. And this is a situation on an image that we see quite often being placed in the Mutterpass, and this is a 15-degree deviation. It actually means that you underestimate the nuchal by about 0.4 millimeters. And if it's out like this, if you do have a deviation of 25 degrees, well, then you do have an average underestimation of about 0.6 millimeters. And imagine if that baby does have a nuchal of 3 millimeters and you underestimate by 2.6, well, then you're back to 2.4 millimeters, and you suspect, or you see a completely normal nuclear translucency measurement, which is just artificial because you're just out and you deviated so much to the side. Now, how does a baby with Downs look like? Well, there are two images here, and you can see the increased nuchal here. It's slightly too bright. Can we do it a bit? Can we make it a bit darker, perhaps? Okay. Well, you can see the increased nuchal on both sides, actually, and an average nuclear translucency measurement in babies with Downs is about 3.5 millimeters. Once again, think about what happens if you do underestimate by 0.6 millimeters. You're back to 2.9 millimeters from that 3.5 millimeters, and you're very close to normal. So therefore, you should keep your measurement as good as possible, or you should do your measurements as good as possible. You can see that kind of flat face even in the first trimester. The nose bone is missing. Not in all cases. It may be smaller here, like in this situation. And actually, I don't have too much time to spend on this, but these are those secondary markers, and If the nose bone is smaller or not as bright as the above-laying skin, then it may be an additional sign for Down syndrome, and it may be worth looking to these conditions if the first trimester risk based on NT and biochemistry is not that bad, but not that good as well. In these conditions, these markers may help, but this is not a particularly good video for this. Look to this one. This would be nicer, where you don't really see a nucleus and nose bone in this situation. With trisomy 18, the nucleus is a bit larger. It's about 6 millimeters, but there are about 20% of the cases where the nucleus is more or less normal. So be careful with nuclear insufficiency measurements in trisomy 18. They tend to be smaller. That's an important size. If our patients very clear about the gestational age, worry about trisomy 18 if the baby is on the 5th side or 5th centile or below, and have a look to the biochemical values. They may help. For beta and papain are very low in cases of trisomy 18. Well, why worry if we do have NIPT, isn't it? And you can actually skip nuclear insufficiency measurements. You do have a screening test that is so much better than first trimester screening, with detection rates of 99% compared to 90% with first trimester screening. And especially the false positive rate is very much reduced with cerebrofetal DNA testing. It goes down to from 5% with first trimester screening to 0.1%. Well, still worry. You still need to be aware of how to measure the nuclear insufficiency, because I don't believe that cell-free fetal DNA will be the only way of screening within the next some years. Okay? This is firstly because cell-free fetal DNA is just too expensive for now, and we do need some triage testing where we do a cheaper screening test. That may be first trimester screening, for example, and then you decide to take, for example, cell-free fetal DNA testing only in the borderline risks, which reflects about 15 to 20% of our population. Okay? And for the other ones, you do have an increased nuchal, for example, or an abnormal biochemical result that brings you to a risk of, let's say, 1 in 10 or something like this, where you would directly recommend invasive testing rather than going for NIP testing. And the same is true for the very low risks. If your risk is, let's say, below 1 in 1,000, one can discuss these cutoffs, of course, but let's say below 1 in 1,000, well, then you do have, in 85% of the cases, you won't do any further NIP testing. And only though in those 15% you would offer cell-free fetal DNA testing. And these kind of contingent screening models will make cell-free fetal DNA testing cost effective, because otherwise it won't be cost effective. And for example, if you take a nation like Germany with 670,000 deliveries a year, screening by cell-free fetal DNA testing would cost 380 million euro. Okay? So you see, no way to get that cost effective, and therefore you need additional screening tests in advance. And also because cell-free fetal DNA testing, at least for now, in terms of chromosomal abnormalities, only face on a small proportion of possible anomalies, and therefore it will be still necessary to have a look to the nuclear insufficiency, because the nuclear actually offers a quick and easy screening test for several other conditions. We know that, of course, the risk for trisomies goes up, for chromosomal abnormalities goes up, but there's also an association with major defects, with intrauterine death, and we shouldn't lose the chance to get these screening tests for major anomalies. Okay? But still, having said that, it's still necessary to focus on the features in a more detailed way, because there's a nice study that looked to the anatomy and of these fetuses and found 86 fetuses with a major defect. In these conditions, the nucleus was increased in 2/3 of the cases, but the nucleus within the normal range in 1/3 of these cases. So still look to the nucleus, it's necessary, and still look to the anatomy, because in fact, if we look to this study that's also been made within the Nicolaides group, they look to the number of structural defects without chromosomal abnormalities and the number of defects with chromosomal abnormalities. And in fact, the number of structural defects was higher than the number of chromosomal abnormalities. And The problem here is that the first trimester screening for these major anomalies provides much lower detection rates than the ones that we know from first trimester screening for chromosomal abnormalities. So there's the necessity to look to these anomalies, and this can be increased. And in that study that I've shown you before, which was done in Germany, the detection rate was increased, was actually almost 80%, was more than 80%, maybe a bit too much, but a general number for recommendations about 50%. Okay, we'll have some more minutes, and I'll quickly go through the defects, but these are very easy to glance. If you see them once, you will recognize them all the time. You see that butterfly sign on one side. You can see that in this condition here, you can't really see the butterfly sign of the brain, because the brain here seems open and bits and pieces of the brains are outside. Well, this will be anencephaly in the second trimester, but anencephaly develops due to contact of amniotic fluid with the brain, and so it takes a bit of time until it gets to an anencephalus. Up to then, you see there's an exencephaly. This is a nice case where you see it quite clearly, but it can be a bit more difficult, like in these cases, where you can only see something here that looks like, like a head of the baby, or in this condition where you just can't see the brain clearly enough because it's attached here to the amniotic, to the amnion, or in these cases where you've got more an anencephalic fetus where you can't see any brain. But in all of these cases, you don't see that butterfly sign, which is a major hint. Well, in the second trimester, that's easy. There, there you see these frog eye faces, and you don't see a face here, and that's the baby that's been born. Another condition that's quite easy to identify by looking to the butterfly sign is alobar holoprosencephaly. Well, lobar holoprosencephaly would be much more difficult, but alobar holoprosencephaly, that's quite easy because you can see that common ventricle or semilobar holoprosencephaly, and that's very easy to identify. Again, these are the transvaginal images, very nice. In the abdominal setup, you can still see clearly enough, but look to the butterfly sign and you won't see that classical butterfly sign in these cases. Remember that in about 2/3 of the cases it's trisomy 13, especially if the nucleus increased. So think about karyotyping, but the outcome is disastrous. Still think about karyotyping, because if it's not trisomy 13, then it may be some other conditions with a higher risk of recurrence. Again, the second trimester, it's easy. Another baby that's been aborted then with the typical structures, and there's always that sign that the brain predicts the face or the other way around. So these fetuses with major defects, midline defects, will have also major midline defects in the face. Go a bit further down, look to the abdomen, and clearly identify the insertion of the umbilical cord. And by doing so, you can easily see gastroschisis even in the first trimester, or an exomphalus. That may be a bit more difficult even in the small cases here, where there's only a small loop outside. The ones with the liver exomphalus, they're much easier to detect. Hurry up a bit. These are nice cases now here of a gastroschisis. And be aware that in the first trimester, it's so easy to identify gastroschisis. And I've seen 2 or 3 cases where it's really difficult in the third trimester because the baby may lay down on the bowel, and you don't really get a good view to the insertion of the umbilical cord. But if you've seen it as clearly as this in the first trimester, so there's no doubt it won't go away if it looks like this. In terms of exomphalus, be aware that before 45 millimeters, it's physiological, so you'll expect an exomphalus at this time, but it's only a bowel exomphalus. You will never see liver outside, even in the physiological cases. Okay? And be aware that in some cases, these bowel exomphalus may disappear, even if the CRLs are a bit bigger. So don't worry too much, wait and see, and do another scan in about 2 weeks, and it may have disappeared by itself. There's always the discussion whether the big ones, the big exomphalus, or especially the small exomphalus, do have a higher risk of being chromosomally abnormal. And it was thought that the small exomphalus do have a higher risk rather than the big exomphalus, the bowel exomphalus. We've done a study with 150 exomphalus in the first semester, and actually the prevalence of chromosomal abnormalities, they were more or less the same. Bowel only was about 56%, while liver exomphalus got a 52% chance of being chromosomally abnormal. Obviously, most of them were trisomy 18s, some of them were trisomy 13s, but the trisomy 18 is the one to think about. The last one to remember is megacystis, again a very easy and quickly diagnosable major anomaly. By just looking to the bladder, which may be difficult from time to time, you can identify these cases where there's, where there's obstructive uropathy, when you can see the urethra, even in the first semester here, and in this condition, the diameter of the bladder is more than 15 millimeters. In these conditions, the chances of this resolving is more or less zero, so you can actually draw your conclusions with that image. You may wait for two more weeks, but at the end of the day, if these patients decide to terminate, there is no necessity to wait. In these conditions here, where the bladder is between 7 and 15 millimeters, there may be a chance of a chromosomal abnormality. It's maybe up to 30%, but again, in those cases where I've seen those semi-sized megacystis, when the nucleus was normal, when the biochemistry was normal, these cases didn't have trisomy 13. There's a minimal chance of these conditions, of these situations running into obstructive uropathy. Therefore, have another look in within the next two weeks, and most of them, up to 90%, will be normal again. So let me conclude. First semester anomaly scanning can detect about 50% of the cases, and you should really identify anencephaly, holobrosencephaly, abdominal wall defects, and megacystis. There are ISUOG guidelines, and they are freely available. Have a look to the internet, to the web, and download it from the ISUOG homepage, and carry on to measure NT, because it's much, it opens your eyes to more than just trisomy 21. Thank you.